Good morning. There, that works. My name is Kim Dupuy. I'm the Director of Oncology Development for Sunrise Hospital here in Las Vegas. And it's my privilege to welcome Dr. Waseem Alhushki this morning, who's going to give a talk on long-term needs of adolescent and young adult survivors. Dr. Alhushki is board certified in pediatrics and in the pediatric hematology oncology. He joined Cure for the Kids Foundation in 2013, where he leads the organization's in long-term follow-up clinic. He developed a passion for pediatric hematology oncology while working at the King Hussein Cancer Center in Jordan. He's volunteered for 3 international missions to help children all over the world with cleft lip and palate deformities, and has participated in designing and conducting workshops on healthy lifestyles, conflict resolution, and teamwork in collaboration with the United Nations Children's Fund and the United Nations Population Fund. He's part of the Children's Hospital of Michigan Pediatric Residency Program, go Michigan,
Go green.
at Wayne State University. And while there, he was honored with the General Pediatric Clinic Outstanding Continuity Clinic Resident Award. Before coming to Las Vegas, he worked at the Children's Hospital of Los Angeles Pediatric Hematology Oncology Program. His fellowship research project focused on the role of weight loss in improving outcomes for obese children and acute lymphoblastic leukemia. Dr. Alhushki has been the recipient of many honors and awards and holds several society memberships, such as the American Academy of Pediatrics, Children Oncology Group, American Society of Pediatric Hematology Oncology, and the Society of Hematology, as well as an outstanding board member for the Make-A-Wish Foundation Southern Nevada chapter. Please join me in welcoming the esteemed Dr. Alhushki.
Oh, thank you. Hello. Good morning, everybody. Thank you so much, Kim, for this kind introduction. And as Kim mentioned, my name is Dr. Waseem. I'm a pediatric hematologist, oncologist at Cure for the Kids Foundation. I also serve as the lead physician for the Survivorship Clinic, which we also call Storybook Homes. Let me start by thanking everybody who has just worked really hard to bring this day together. It is an honor to be here today to talk to you about a very special group of patients, and those are the adolescents and the young adults. Those, by definition, are the patients who have received their cancer diagnosis between the ages of 15 and 39. So our main goals from this presentation are really going to be around 3 main points. The first is going to be to review the history and the standards of survivorship. The second point is going to be about discussing the AYA, and that's the term we're going to use for adolescent and young adults through this presentation. We're going to talk about their special, unique survivorship experience. And the third point is really to present Cure for the Kids survivorship experience, which is really designated as Storybook Homes. We want to share with you our achievements over the last few years where we had this clinic at Cure for the Kids. Now, those were the main goals, but there's always, in my mind, while researching for this presentation, I really want to thank the coalition for extending this invitation. But it really had me go back all the way in time to start just to understand how everything started. So in the 1940s, which is around World War II, we did not really understand what cancer is. The mainstay of treatment at that point was surgery. It was not uncommon for your doctor to send you home with a cancer diagnosis without telling you you have cancer diagnosis. That was the common practice. We did not understand what cancer is. It was a really scary word. Due to the unfortunate events of World War II, we found something good in there. Scientists discovered that nitrogen mustard, which is a chemical weapon, has really curative effect on certain types of cancers for the lymph nodes, lymphomas. They did not understand a lot about that disease, but the talk was starting to happen. And one of those brilliant minds was Dr. Sidney Farber. So Dr. Farber, who's the person on the left of me, so he was a brilliant pathologist at Boston Children's Hospital. He was convinced that he can treat cancer using medications, and especially childhood cancer. He worked in the lab at Boston Children's Hospital. It was in the basement of the lab on mice, rat experiments to prove that treatments can cure cancer. And through some public involvement and community support, and also through Boston Children's Hospital, he was able to enroll his first clinical study with patients who had leukemia. The number were 16 kids. Those kids had dismal prognosis. Everybody died in those years. Out of those 16, using a folic acid antagonist, which is at this point is one of our still mainstay of treatments, which is our methotrexate. He used that as an IM injection. And out of those 16 kids, almost half went into remission, so they actually responded to treatment. And more than a third survived for 6 months. Unfortunately, they died after that. But that was a huge change in the mindset of how we treat cancer. He proved that you can actually bring people into remission using cancer medications. He published his first article in the New England Journal of Medicine. It was 1948. And this publication, fortunately, caught the eyes of a person who will go on to be known as one of the most important figures in the fight against cancer. See, in the back of my mind while researching for all of this, there was two main points that just kept popping. The first was the public involvement in this endeavor, in this survivorship movement, was absolutely vital. We are talking about non-medical, non-doctor, non-scientist people who believed in the idea and shared their vision. So I'm going to highlight that through this presentation. And the second point is, I do want to share with you a lot of numbers and stats, hopefully, but I also want to convey that feeling of understanding, appreciation of what survivors really have to go through their daily lives. So I tried to have points of this presentation just more about people rather than more about the disease. So Mary Lasker was not a doctor. She was not a scientist. She was actually a businesswoman. She had many art galleries. Her husband, Albert, was a millionaire. He had ad companies. She read Sidney Farber, and she was convinced, and she believed in his idea. And she visited him within a few years. She supplemented him with a lot of resources through his first research. She convinced her husband to quit his job. She opened a foundation to fight against cancer. She was involved in the initial parts of the whole reformation of the board of the National, at that point it was called National Society for Cancer Control. She worked really hard, and in 1951, her husband, Albert, he actually died of colon cancer. And once that happened, she just went to work. She worked with Dr. Farber and many others. And, you know, apologies to everybody who I'm just going to mention in this history because I can't fit everybody there. Through her belief and their shared vision that the nation has to be invested in this cause. She ran so many public ads, she talked to so many people, but the main turning point was 1969 when she went out of her way and she published this ad in Washington Post, in the New York Times. It cost around $160,000 in the modern time money. And in this ad, she challenged Nixon and all the Congress people that if we can send a person to the moon, we can cure cancer. She quoted Sidney Farber. She quoted Dr. DeVita, who had very early publications for cancer control. She also compared the lives lost in Vietnam to the lives lost for cancer, which are almost twice as much. She called the people to write to the Congress. She called the people to write to Nixon. And within a few days, thousands, probably millions of letters flooded Washington. It made them at some point have a Congress hearing, and there's a whole story of how eventually that led into the signing of the National Cancer Act in 1971. So in 1971, with this signature of the National Cancer Act, the chances for research completely changed. The budget of the National Cancer Institute at that point was not called that, but that the money available for research increased from around $100 million to around, well, $180 million to around $1 billion. That increased the amount of data, the amount of clinical research that just flooded over the next 20 and 30 years. Through this work and through all of these pioneers, we are now at a point in the United States where you can see we have around 18 million survivors as of 2022. Those are split almost half between males and females. We're expected to have around 26 million survivors in 2040. Globally, we have at least 25 million survivors if you want to think globally too. The types of cancers are the three most common remains, as in males, prostate, melanoma, and the colorectal cancers. In females, they really remain high with breast, uterine, and thyroid, and there is the breakout of the types of cancers we have. If you can look at this, you know, the late effects that, the long-term side effects that survivors have to go through are split between so many things. There's social, emotional, psychological, physical limitations. When you look at them in this fractionated way, it is really hard to serve the cause of monitoring and helping these survivors live their lives. So that brings us naturally into the definition of what is a survivor. We have many definitions for survivors, and some of them are from the National Coalition for Cancer Survivorship. There is also an NCCN definition, but really the closest to my heart probably is going to be Dr. Mullen's definition, who is the first director for the National Coalition. And he said that survivorship or survivors are defined as individuals who had cancer, and that starts at the time of the diagnosis throughout their life. So the old definition of what a survivor is really changed through time. And before we had such definitions of a holistic way of how to look into survivors, things were really fractionated. In the 1980s, you could not just go Google cancer support group. You could not just go find somebody to talk to about cancer. The term survivor does not exist. At that point, we used more cancer victims. In the 1960s, Dr. Fitzhugh Mullen, he was a young pediatrician. He lived in New York. He was involved in all of his 1960s and 70s civil rights movement. He went down to the South. He volunteered there. He came back up to New York. And while he was writing some political articles at the age of 32, he was diagnosed with lung cancer. He had one daughter called Caitlin. She was 4. His life just got changed overnight. He had to undergo multiple surgeries, chemotherapy. Through his surgeries, he had so many complications that they had to take his sternum or breastbone out. You can, per the reports, you can see his heart beating through his skin. They had to suture his arm into his body so he can actually create some blood flow there. After recovery within a few years from that, in 1975, he published a book called Vital Signs. And Vital Signs was really his talk about his anger of having cancer at that age, his fears about his daughter's future. He talked also about the joys of surviving cancer. That book had so much buzz around the country. He went everywhere. He went into night talk shows. He went into a lot of National Cancer Coalition groups, and he talked to everybody about vital signs and what does it mean to be a survivor. 10 years after that, he took some time to recover, and he regathered his ideas, and he published this very seminal article in the New England Journal of Medicine, and that was in 1985, and it's called Seasons of Survival. In this very important article, he coined the term cancer survivor. And since then, in a way, we faded away from using the term cancer victim. He also talked about phases of survival. He talked about an acute phase. You just got diagnosed, you're getting chemotherapy. Extended phase. That's the phase when you just finished chemotherapy, but the risk of relapse is high. You're always anxious that the cancer is going to come back. And you also have physical and emotional limitations. And then comes the permanent phase, which means this does not stop. The chances of the cancer coming back is low, but I still have physical, emotional, and psychological limitations. He also called in that article for a cancer alumni. That resonated with thousands, probably millions around the country. And one of these really important people was Catherine Logan Carello. She was a cervical cancer survivor, also went and volunteered with the civil rights movement. She had that deep passion that she wants to change the world. After her diagnosis and chemotherapy and surgery, she moved to New Mexico. She started her own support group. Nobody wanted to help her. At some point, the doctors were angry at her that she was talking about cancer survivorship. They actually referred her for a divorce group. And she sat there and she did not understand, why was I referred for a divorce group? She did, in her own porch of her apartment, more than 86 communications, successful communications with organizations, hundreds, she called hundreds of people, just to talk and create social groups. She was the first person to create what we call now People Living Through Cancer. And through her work and other people that I can't really mention all their names, they started this movement around that time in the 1985. She reached out to Dr. Mullen because she read in his article that we should have a cancer alumni. She reached out and she asked him to come to New Mexico in 1986 on a weekend where more than around 1,000 survivors met, and they created at that point the seed for the National Coalition for Cancer Survival, or Cancer Survivorship. And through their work and through their hard sharing of their experiences, because a lot of the people who started this were really cancer survivors, we now look at cancer survivorship more in this holistic way. We talk about quality of life. We don't talk about physical, emotional, and we send you into multiple places to see. No, we want to look at you as a whole. And that's how we get that through all of that work, through all of these publications. The Children Oncology Group is a national coalition for clinical trials supported by the National Cancer Institute. Has more than 200 member institutions. They're very much aware of the survivorship issue, and this also culminated eventually in the early 2000s in the production of specific recommendations for the surveillance of risk factors and adverse reactions and long-term effects from cancer chemotherapy. And that's why now we have what we call long-term follow-up guidelines. Those are updated every 5 years. They called in this survivorship guideline into four main groups, or sorry, into four main missions. And a lot of these have to do with giving the survivors the right of having a comprehensive view of their problems. So they called also in this movement into the building of what we call now survivorship plans. We will share that with you hopefully within a few minutes. And also within those long-term follow-up guidelines, they really meant to target not just oncologists and pediatric oncologists and people who are involved in the cancer and the oncology world. They really wanted primary health providers and primary pediatricians to be able to screen for long-term cancer survivorship problems. These guidelines are easy to be used. The tests are easy to be ordered. Now, authorizing them, that's a different problem. We'll talk about that in disparities. But these are supposed to be simple guidelines to help you guide your survivor through that journey into recovery. So for the AYA group specifically, sharing some statistics, the AYA group, as of 2022, we have almost around 85,000 diagnosed AYAs. They represent almost 2% of all invasive cancers. The problem is, which also has been highlighted since the early 2000s, is that the cancer incidence continues to rise. We have a rise of around 0.3% every year, all the way up into 2019. That's due to certain cancers like thyroid, and uterine and breast cancer. Also, it is the most common cause of death from a disease among males and females in the AYA group, excluding homicide and unintentional injury and suicide. It is the leading cause of death in AYA group. Their survival rate for all cancers in the AYA group exceeds 85%, which is a great number. But for certain types of cancers, it is much lower compared to the other groups. If we look at what kinds of cancers does the AYA group have, it is split between multiple age groups. The early age group is the 15 to 19, so you're going to see mostly the thyroid, the thyroid, lymphoma, and the brain cancers. Once we cross above the 20 years of age, you'll have also the entry of, or the lymphomas are going to be a little bit more common, in addition to your thyroid, and the testicular germ tumors start to be more often, especially once you cross to that early adolescent or the early 20s. And then once you're above 30, the breast cancer makes its impact and it becomes one of the most common that we see, especially among females. So what is really unique about our AYA population? Well, first of all, they have 1.5 risk of dying from a recurrence or a progression from their cancer. The second is that 14% of AYAs are going to develop a subsequent cancer in their lifetime. AYA group also, in general, have worse overall psychosocial functioning. We have many studies since that movement toward making AYA survival better. We'll talk about that in a very important early 2000 COG call to the National Cancer Institute to look into this very specific problem. Why do AYAs have worse survival? Why do they have increased cancer incidence? They have substantial disruption in their school, in their career. It is the time when you're just about to take the world and suddenly cancer just comes out of nowhere. They have special difficulties with fertility, sexual functioning, self-body image. We'll talk about fertility as one of the most important things that we are really now aware of while we talk about that first diagnosis. And also, they tend to present at a more advanced stage for multiple reasons. Access of care disparities, in addition to having a very low insurance rate. They are one of the most group that has low insurance in general. They are underrepresented, underserved, and understudied. So in the early 2000s, COG sent this important report called the AYA Gap that basically asked NCI to make special attention or pay special attention into the AYA slow improvement in survival rates. And they had very specific recommendations up from this letter of communication. The NCI responded by redirecting more funds. And since then, we have now more and more AYA-specific designed studies and clinical trials. So the first data I want to share with you has to do with unmet needs of AYA population after cancer diagnosis. These are AYAs. They were recruited from 7 different population-based cancer registries. We send them questionnaires, median about 6 to 15 months after diagnosis. And we ask them multiple questions. How do they feel if their needs were met in different categories? So we have handling concerns about getting another cancer, getting physical therapy, getting pain management service, talking about my risk of having another cancer. We also looked into survivors who had more than 6 unmet needs as a marker of people who have a high risk group probably. Now, you can see that more than 50% of survivors said that they had unmet needs related to physical, long-term side effects, getting pain management, and a little bit lower, between 25 to 50% had unmet needs related to other issues that have to do with seeking sexual counseling or psychological counseling. Out of those survivors who had very specific services or needs, there's a high need for services that have to do with pain management, having a support group, getting professional advice, to get a payment for healthcare, helping me financially. In the same AYA study that was released probably in around 2010, and then they had much more follow-up on it later, they also asked the AYA survivors if they have been told that the treatment is going to be affecting their fertility. And in our US population, more than 70% of survivors said that I was told the treatment is going to affect my fertility. So that leaves 30%, right? Few issues popped up from this report. 18% of males were told, and almost 38% of females were not told that the treatment affects fertility. And this is two major parts. The first is being told that it will affect your fertility, and the second is being able to do sperm banking or fertility banking or ovopreservation. That's a whole other story that have to do with funding and the timing of it. In that specific study as well, there were certain disparities that were looked at, like Hispanic patients, patients who did not have high education, they were more likely not to be told about fertility. They also, these are the fertility data that I just showed you, and especially with the Hispanic and the less education, or people who have less education or less than high school education. They are more likely not to be told about their fertility. Think about that. And again, this is data from the 2010. Things have changed. There's a huge push now from the NCI, the COG. It is built in our protocols that you have to discuss fertility. You have to discuss the option for the fertility preservation. But we don't have the means to support that financially. And we'll talk about exit points for that or bypasses. A lot of the people who said they did not do their fertility preservation, although they were told, had to do with reasons of, I wanted to get treatment first, I did not have enough money, it was not covered by insurance. Other reasons have to do with more personal issues of the belief of having babies. But if we look at the percentage of patients that those tests that were recommended by the doctor were covered by insurance or not, 20% of the AYA survivors said that those tests recommended by the doctor initially were not covered by insurance anyways. The bigger problem is 80% of those 20% still went ahead and did the test. So it speaks about that financial burden, right? Because that means you're going to have to go out of your way to find money to get that fertility preservation done in a very limited time. So that also brings us to few data and studies that really shows that AYAs have higher rates of bankruptcy for multiple reasons. The insurance issue is a problem that has been looked at also in multiple studies. In questionnaires sent to AYAs for an average of from diagnosis all the way up to 15 months after diagnosis, and then followed up to 35 months, almost 25% of AYA survivors reported they had no insurance for a period of time, up to 3 years after diagnosis. So up to 3 years after I was diagnosed, there was a period where I did not have insurance. And we see that every single day in our own practice. And it is a problem in giving you the standards of treatment on time. So when we talk about standards of treatment, it is not applicable in the presence of disparities. So we have to create other channels to bypass that. And Cure for the Kids were very much aware of that problem. And Cure for the Kids Foundation is a non-for-profit foundation that was established in 2006. It is a hybrid model, and that's why it's really close to my heart. So that means we have a combination of a very rigid structural clinical modules, clinical data. We have clinical studies. We are a children oncology member. We enroll patients in studies. We have rigid clinical standards of care. But at the same time, we have a very close and compassionate arm of philanthropy. So that allows the medical team to provide care without having concerns about financial issues or having issues about authorizing medical tests or certain diagnostic procedures. Our mission lays on the basis of there is no child that should be deprived of clinical care because they can't pay for that service. So we have our own charity care program. If you are uninsured anywhere, I can see you next day in clinic because we make those channels of communication and because we bypass a lot of the rigidity of the structural big hospitals. And nothing about, I'm from a big hospital, I trained there. But it takes time to do things. So you have to be able to provide a comprehensive care in a clinic setting, not in a hospital acute setting. You can't come from comprehensive help somebody in acute setting when they're getting chemotherapy in the hospital. They're not going to talk to you about school. They're not going to, it is too early. So we have to be able to provide these means outside a hospital setting. And that's where Cure for the Kids comes. We're a very busy place. We have more than 6,000 infusions. I think this is 2022 data. We have more than 13,000 hours administration of drugs. We have more than 130 biopsies, more than 500 lumbar punctures. We saw almost 35,000 outpatient visits and hospital visits in 2022. We are a part of the oncology group service. We have clinical studies open with the children oncology group in addition to other companies and pharmaceutical companies because we do want to reach out to the other population as well that can benefit from that. We also have something that's really dear to my heart, which is the educational center. And that really kind of exemplifies that holistic approach we're talking about. We have our own school district teacher who can actually help our patients navigate through their treatment and their education, helps with 504s, helps with IEPs, comes to you with the meeting for the school so we can talk about how does it look over the next month. We're very in direct communication with the educational people. Inside Cure for the Kids, it harbors Survivorship Clinic, which is storybook homes. And as you can see in Mary Lasker involvement at the beginning and all the public and community involvement in the survivorship movement, this was also pioneered and also kind of born out of the community. And due to that really generous gift of Wayne and Catherine Lasker, who are also the parents of a survivor, they really wanted a place where they can get questions answered about what is the long-term side effects of these cancers? What things should we look for? Can we help him adjust for his school? And these are very common questions between our survivors, right? Work environment. How can I go back to my work environment? It is sad when it comes to a point that there is definitely disparities against people who have history of cancers, probably not very clear, but by all means there are. They're probably, and we have studies about that, they're less likely to be hired. At the Survivorship Clinic, when you come in, oh, this is an old picture. So we have a bigger team, okay? We're like 12 people in that comprehensive survivorship. We do also have a comprehensive sickle cell clinic. So on that table, we have a neuropsychologist, we have a social worker, we have a dentist, we have an occupational therapist, we have our own educational person, we have at the same table as well the doctor or the pediatric hematologist, oncologist. Before you come to our comprehensive clinic, our great nurse navigator will go through all your treatment, all the chemotherapies that you've got. She's going to create this great folder that we call Survivorship folder. And in that folder, we really give you the summary of all your cancer treatment. Your demographics, where were you treated, what protocol, what chemotherapies did I get, how many doses of them. We calculate all, and this is all standards of care from the Children's Oncology Group, which means if you go any other place, you're going to get the same exact recommendations. It is purely built and directly individualized to each patient. depends on how many doses you got. What is the higher dose of the heart medicine you got? How many times should I get an echo, or how often? At the same time, we also create for you contacts for healthy means for you to get healthier. We give you a lot of healthy handouts at the end that are really directed or specific to your diagnosis. This is not just chemotherapy. We have a lot of patients who get surgery and radiation, and those long-term follow-up guidelines are meant to help any patient who has a history of cancer with an intervention that was done. Now, this is supposed to be a living document. It is updated every year through what changed from the last time we saw you. And we provide you with an updated version of that every year. At the Comprehensive Long-Term Survivorship Clinic, we have seen increased numbers between 22 and 2023. And it is a pleasure always, and it just makes our heart jump of joy when a survivor moves into Nevada in the 30s, 40s of his age, and he calls our clinic directly to make an appointment with the Survivorship Clinic. Because that means we finally got to a point where we can reach people who really needs us. They are not worried about calling and insurance purposes or who's going to refer me. We do not care about that. We have the means to bypass that. But that also means we do depend on the support of a lot of local organizations. I mean, this is a build-out for the last 15 years of communication, and it's hard work to build bridges with our community people. The NCCF candle lighters. We have direct communications with pediatricians. We've worked hard to do that, where it comes to a point where a pediatrician is going to call me just now and ask me a question. We do want to get that point of time where we have that ease of communication for the care of our survivors. So in 2022, we saw, I think, around 140 survivors. 2023, we're almost around 70. Our biggest percentage, more than 60%, is AYAs. And the diagnosis breakout still remains with the highest with the leukemias, and then comes our solid tumors. The AYA group committee at the Children's Oncology Group is very much aware of that AYA gap. They have pioneered that report in the early 2000s. And we are coming to a point now where we have specific designed clinical studies that target AYAs. We have more than 11 open COG-led AYA studies. So there are COG members or within the COG member institutions. We have more than 6 open non-COG adult AYA studies, as you can see them there. We also have under construction more and more studies that are really truly designed for our AYA survivors or adolescent and young adults. You know, at this point of time where we have such a rich amount of these clinical studies that are really just designed for AYAs, it is the culmination of the work and the vision of so many people. Start from Dr. Farber all the way until Dr. Fitzhugh-Mullen and many, many others after that. Dr. Mullen died in 2019 from the complications of his lung cancer. And it took him 10 years between 1975 and 1985 to crystallize these ideas about survivors. His first book was more about the anger, and the feelings and the joy. And the 1985 Seasons of Survival came more with very clear recommendations, but they were wrote beautifully. He talked about his cancer diagnosis as a badge of honor on his chest. He generously shared his thoughts with millions of people. And because he was generous enough to share this article, thousands of people, and millions probably, of people's lives have changed. In that seminal article in 1985, it truly served as the catalyst for this national survivorship movement. And he served as the first director for that National Coalition for Cancer Survivorship. So in Seasons of Survival, he wrote, "It is as if we have invented sophisticated techniques to save people from drowning, but once they have been pulled from the water, we leave them there. We leave them on the dock to cough and splutter on their own in the belief that we have done all that we can. And those words just resonated with millions around the United States and probably around the world. Looking back at all of this presentation, you can see how this sharing of ideas and thoughts is absolutely probably one of the most beautiful aspects of humanity. Because Dr. Farber believed his idea is not his, and he shared it with the world, people like Mary Lasker read and believed in it. And because she believed in it, so that sharing soul is really what this story is probably about. And I think this conference is a huge exemplification of that soul of sharing. So thank you so much for having me. And at the end, we'll talk some questions, if anybody has questions for me. And